why are we looking at all this fluid overload and congestion? See here, every aspect, every system of the body is affected by congestion. Cerebral edema, end stage, a few things, cerebral obtundation at end stage heart failure explained. Myocardial edema, extremely important. First 24 to 48 hours, depending upon the myocardial edema, your inotropes may not give you the best results. Pulmonary edema, we know. Renal interstitial edema is a important part of cardiorenal syndrome. Hepatic congestion, we know it gives rise to decreased appetite and fullness of stomach with very small feeds. Gut edema, extremely important, because if you do incomplete decongestion and discharge the patient, the amount of oral diuretics required is very high because the absorption less because of gut edema, and tissue edema we all know. So every aspect of the system has some clinical implication in this congestive phase of heart failure. Classification, intravascular and tissue congestion. Now, what is the pathophysiology? We all know this. Activation of the renin-angiotensin-aldosterone natriuretic peptide axis, sodium water retention of the kidney, and one important point, which has clinical implication. Endogenous fluid reservoir, the splanchnic circulation, the splanchnic veins are an important aspect of as a fluid reservoir. What happens is the veins, the splanchnic veins have alpha receptors, and any surge in adrenergic activity suddenly constricts these veins and shifts the fluid from the splanchnic circulation into the intravascular volume, causing pulmonary edema. Why is this important? For two reasons. Number one, these so many patients which you see, hypertensive patients who go into pulmonary edema with not necessarily a very high blood pressure. It is not 240, 220, 240, but increased adrenergic drive. So a significant part of pulmonary edema with a high adrenergic drive, despite the BP not being in the 200s, is caused by this particular mechanism. The importance is nitroglycerin vasodilates the alpha receptors in this splanchnic circulation, and that's why it works in pulmonary edema, one of the mechanisms. Imbalance tissue congestion, hydrostatic and oncotic pressures. I am not going to details of this, but just to tell you four important pathophysiological factors, out of which, remember, lymphatic system is extremely important. It removes fluids, and that is why chronic congestion, chronic rheumatic heart disease, despite the LA and pulmonary artery pressures exceeding the pulmonary wedge pressure exceeding 25, chronically the lymphatic system removes fluids, and that's why despite the actually pulmonary edema point of 25, they will not develop pulmonary edema. That's one. And number two is vascular permeability is subset dependent. Okay, so diabetics, ischemic patients, and patients with sepsis can have vascular permeability problems, which will cause pulmonary edema at a lower hydrostatic pressure. Remember this. That's the importance of this pathophysiology.